An introduction. And thank you, everyone, for being here. It is a pleasure for Lauren and I to share with you some of our main findings and some of the lessons learned that we have acquired through this journey of working together. So I will present the first part of this talk. It is about the epidemiology of HIV in Manitoba. Um, I do not have any conflict of interest to declare. This is the land acknowledgement. The University of Manitoba is located in Treaty 1 territory and on the original lands of Anishinaabe, Illinois, Anisinuak, Dakota, Oyate, and Dene people and on the homeland of the Red River Métis Nations. But beyond the traditional land acknowledgement, I want to reflect that we are in 2025. And after 4 years since the HIV epidemic started, here in Canada, there are unacceptable health inequalities and inequities that disproportionately affect Indigenous peoples. And this is very relevant considering what we are going to share with you today. We always start all our presentations acknowledging that the research findings that we are going to present today, it is a team effort. It's not just one or two persons that you can see today. It is also a huge effort from so many people. And we always start with the All Together for Ideas peer research team. This is an incredible team composed of people with lived experience, trainees, and we are guided by the elder Margaret Lavalley and Chantel Daniels, who have taught us incredible lessons on how to meaningfully engage with, in particular, Indigenous communities and how to apply the concept of reciprocity. This is also the phases of all the incredible research that we are going to share today. Again, this is not just one single person. There are many, many people here, researchers, the Manitoba HIV program, team leadership, people with lived experience, trainees in all phases or their careers, and several clinicians and other researchers across Canada and worldwide. So to start, we want to share with you some of the HIV and STI epidemiology in the prairies. I want to start, this is our latest research, and this is just to mention that between 1990 and 2023, the last 5 years have had the highest rates of sexually transmitted and blood-borne infections of the last 20 to 30 years. As you can see here, for the sake of the comparison, I wrote the rates for 2021. So here are the rates of Canada, Manitoba, Saskatchewan, and Alberta. And this is a comparison between Canada and Alberta by females compared to Manitoba and Saskatchewan. As you can see here, the rates, as I mentioned, have increased in Canada, across Canada, and also in the prairie provinces. We have seen the highest rates of the last 20 to 30 years. But what I want to highlight is that Manitoba, Saskatchewan, and Alberta report the highest rates of chlamydia, gonorrhea, and syphilis. And in the case of Manitoba and Saskatchewan, also the increasing rates of hepatitis C, hepatitis B. In the case of human papillomaviruses, we've seen that the rates in females have decreased, the rates in males have increased, but in both sexes, it has increased the rates of HPV or the rates of cervical, oral, and anal cancers due to HPV in both sexes, as I mentioned. But one critical gap that we must, as clinicians, that we may increase is the vaccination uptake. As you can see here, the rates are between 40 to 65%. The second message of this slide, and probably one of the most important, is that females in Manitoba we have a female epidemiology. As you can see, females are equally affected by sexually transmitted infections. One of the main findings that we identified, so as you can see here, the vertical axis is the rates of HIV per 100,000 population. The horizontal axis is the years, starting with the first cases reported back in 1977 up to 2022. And as you can see, as we all know, most of the epidemic of HIV happened in the 80s. It was where we saw the highest rates ever. And in the 90s, we saw higher rates when it started to report all of the new infections. And what we want to highlight here is that Canada overall has decreased its HIV incidence. However, what you can see in the green line, this is Manitoba, is we draw a trend line. Manitoba is the only province in Canada that has an HIV rate that has increasing over time. Saskatchewan had a peak in the 2009, received some investment and decreased the HIV rates. However, its HIV incidence increased over time and reached the highest in 2021. From these findings, Manitoba and Saskatchewan consistently are the two provinces that report the highest number of cases in Canada. What we want to highlight is that Manitoba, Saskatchewan, and Alberta represent 16% of Canadian population. However, between 2021 and 2023, contributed to close to 40% of all new HIV diagnoses in Canada. So we really need some help not only at the local level and the provincial level, but also from the federal government to be able to address this epidemic. In this figure, we represented the new HIV diagnosis worldwide in 2023, reported by the World Health Organization. And this figure is divided by the World Health Organization regions. So the global incidence is 17 new HIV diagnoses per 100 population, and the other are the World Health Organization regions. In this figure, we depicted the rates of Saskatchewan, Manitoba, Canada, and Alberta, just to show you that Saskatchewan and Manitoba has higher rates compared to European regions, regions of America, Southeast Asia, Eastern Mediterranean, and Western Pacific. So we really have very high rates, and we have communities where our rates surpass 100 cases per 100,000 population. Considering that we are in 2025 with highly effective antiretroviral treatment, pre-exposure prophylaxis, these findings are unacceptable. This data is from the Public Health Agency of Canada. This 20 cases per 100,000 is the report of the government of Manitoba, HIV statistics. But what I want to highlight is that both the Public Health Agency of Canada and the government of Manitoba report do not account for, they only report the new HIV diagnosis. They do not account for all people referred to the Manitoba HIV program, which includes immigrants and newcomers transferred between provinces or people who were diagnosed in their country of origin and currently are living here in Manitoba. This is extremely important because, to give you an example, between 2018 to 2023, there were 257 new people that the Manitoba HIV program is taking care of, but the resources of the program continue to be the same. This is a comparison that we want to depict between the HIV diagnosis in Canada and between the HIV diagnosis in Manitoba. For the sake of the example, we took 2023, so it's comparable. So this is female, this is male. Same here, females and males. When we want to illustrate, from Canada is the latest report from the Public Health Agency of Canada. And from Manitoba is our research. And what we found is that in Canada, 2/3 of the HIV diagnoses are reported in males. However, in Manitoba, the ratio female-male is the same. The main mode of HIV acquisition in Canada is gay, bisexual, and men who have sex with men. However, in Manitoba, this group represents 14%, which is important, but much lower than the Canadian report. The main mode of HIV acquisition in the province is heterosexual sex and injection drug use, mostly crystal methamphetamine, which is important to mention because we do not have opioid agonist therapy for crystal methamphetamine or a similar treatment. And one of the key differences in our epidemiology is that when you look at the data of a self-identification of new HIV diagnosis, indigenous people represent 41% of females and 13% of males. However, in our province, it represents a significant proportion. There is an overrepresentation of indigenous people, 85% in females and 68% in males. So these are key difference in our demographics compared to Canada. And another key difference is that Manitoba has a cis gender epidemiology mostly currently. So as you can see here, this is the data by gender. So we collected data disaggregated. Here we aggregated by man, women, transgender man, and non-binary and unknown data. As you can see here, most of a new HIV diagnosis self-identify as cis men and cis women. One of the important differences is that people are experiencing social structural barriers and multimorbidity. So the numbers in the upper part corresponds to females, the numbers in the lower part corresponds to males. And what you can see here is that 43% of females and close to 30% of males newly diagnosed with HIV were experiencing houselessness. One important comment is that 11% of females and around 17% of males were diagnosed in prison. This is important to mention because many people access healthcare, unfortunately and fortunately, while they are incarcerated. So it's an opportunity for access STBBI testing and treatment. Another key finding that we identified is that 64% of females and 44% of males had a prior sexually transmitted and blood-borne infectious diagnosis. This is extremely important because it is a missed opportunity to prevent HIV diagnosis. So if we have a person that has an STBBI diagnosis, and the person doesn't have HIV, so it's an opportunity for us to offer HIV pre-exposure prophylaxis in addition to other STBBI prevention strategies education. Another important finding is that around 80% of people were experiencing multiple conditions at the same time. Among them, STBBI was the most common, and the second one was mental health conditions. So you can see that 46% of females and 35% of males had an associated mental health condition. And one of the most key differences is substance use. In our study, 85% of females and 75% of males use two or more substances. So people combine, for example, stimulants with opioids or many other substances, which increase not only substance use mortality, associated mortality, but also pose other challenges to how properly support people who are using substances. And one of the main differences is that our epidemiology is mostly crystal methamphetamine, so 76% of females and 51% of males. When we look at those conditions, people are experiencing multiple concurrent conditions. So in this case, what we want to illustrate The panel A is females, the panel B is males. And what we want to illustrate is that 82% of females and 62% of males were experiencing simultaneously two or more conditions in addition to the HIV. So in this case, one example is 23% of females were newly diagnosed with HIV, and at the same time, they were experiencing houselessness, they were experiencing mental health issues, and they were using injection. They were using injected crystal methamphetamine. So this illustrates that to address HIV, we need a syndemic approach, not just focusing on HIV treatment. One of the most important key indicators worldwide is that 95% of people newly diagnosed start antiretroviral treatment, and that 95% of those achieve undetectable viral load. So in our study, we are far from that 95, but let's say that around 80% of people started antiretroviral therapy, which these numbers differs by sex, by housing status, and by substance use. But the main challenge that Manitoba is facing is that people start antiretroviral treatment. Unfortunately, due to those social and structural conditions, people are not achieving undetectable viral load, which is critical to prevent a transmission in the community. So you can see that in general, the proportion of undetectable viral load is around 60% and is lower among people experiencing houselessness and people who use opioids. Here, I want to share, we completed, we interview people living with HIV, we interview HIV service providers, and when we look at the barriers, we look at the barriers and facilitators. When we look at the barriers, people reported that they are experiencing multiple barriers at the same time. So not only focusing on HIV, but also other conditions, substance use, housing, mental health status, and COVID-19 pandemic. So the most important barrier that people are experiencing is multiple hardships. So for example, unstable housing, substance use, people name it as addictions, mental health. So a significant proportion, close to 80% reported unresolved trauma. We have a gender differences between the HIV epidemiology. So women reported more intimate partner violence, multiple types of abuse, so sexual, physical, psychological abuse. Another barrier was that primary care and emergency services. So many people reported that in these levels, they did not receive post-counseling HIV diagnosis. They also reported stigma and discrimination by some primary care providers and emergency workers. People also reported the stigma and discrimination from family, friends, loved ones, and communities. Many people left their communities because of the discrimination that they face in these places. And one of the significant challenges is that people really struggle with healthcare services within the traditional working hours, Monday to Friday or Monday to Saturday, from 8, 9 to 5 p.m. And one of the most complaints was the long waiting times. Among the facilitators that people reported were the current HIV clinics. People like 100% of people highlighted the support that they receive from the current HIV clinics. They receive wraparound services, welcoming and safe spaces, clear explanations about HIV diagnosis, treatment, and how to live with HIV. As well as support from other HIV service providers. They also reported that some social support, such as bus tickets or food banks, housing and financial support, helped them to be engaged in care. In addition to emotional support, for example, peer connection, skill development workshops, mental health counseling when it was available. And one key important thing is they develop resilient strategies and empowerment while they were learning and accepting their HIV diagnosis, and more education, and willing to support other people newly diagnosed with HIV. So there are barriers, but also there are facilitators that we can expand and scale up. When these are some of the stories that people share with us, and this is just to illustrate that women, for example, experience terrible intimate partner violence. And in the case of men, for example, they experience a lot of street violence where people, for example, they were houseless, and someone steal their belongings, including their HIV medications. So there are many stories related to why uh, external conditions prevent people from being engaged in care. That is, in some instances, people used to blame patients, but actually there are intimate partner violence and other type of violence that prevent people from be fully engaged in care. So when we talk about the barriers and facilitators of the HIV service providers, this includes several service providers that we interview. So there are structural factors, for example, a lack of limited mental health or substance use services, limited funding, social, cultural, community level barriers such as stigma, discrimination, racism. Institutional level, this is one of the most critical one reported by providers and patients. So lack of an integrated primary care for people living with HIV. Usually the primary care doctor see one issue per appointment, and usually every 3 months, which is considering the comorbidities that people are experiencing, this is not feasible. One important thing that we want to highlight is the burnout, moral distress, stress, and frustration that HIV healthcare workers are experiencing. Among the facilitators, having non-judgmental care and safe, non-stigmatizing environments, focus on building relationships and trust, collaboration with clients and other providers, and having effective policies and sustained funding. For example, Manitoba only last year announced universal ART and HIV PrEP. And of course, supportive workplace where staff receive training, listening to feedback and acting on that. When we last year, we conducted a massive community consultation using different strategies with several partner organizations, because we wanted to listen to marginalized communities, indigenous peoples, people experiencing houselessness, people who use substances, immigrants and refugees, among others. We listened to over 400 participants and included, in addition to people with lived experience, staff and healthcare providers and directors, managers, and public health workers. And what we found was that people have competing priorities where they have existential needs. And when they have the existential needs, health become in the bottom of the priorities. So the most pressing priority that people have is housing, followed by drug use and addictions, followed by mental health support, and as fourth priority was healthcare services. So this is important to understand, and here we are calling that for a to be able to address HIV epidemiology in Manitoba, we need other multi approach. To finish my presentation, what we want to highlight is we have many needs. So in our research, we found that people are having multiple co-infections, sexually transmitted and blood-borne infections, sorry, skin and soft tissue infections, pneumonia, tuberculosis, life-threatening conditions not associated directly to HIV, such as endocarditis. But we have opportunities with the current existing funding. So opportunities to test for all, to offer PrEP and PEP, vaccines recommended for people living with HIV, harm reduction supplies. We also found multimorbidity, so mental health, substance use, and chronic conditions. So we need to offer wraparound services for example, mental health support, addiction medicine, and involve other specialties, so internal medicine, other disciplines that are part of the comorbidities that people are experiencing. And one important thing is social and structural, so homelessness, intimate partner violence, access to care. So offer social services. We want to highlight not only the important role of social workers and transitional housing, also there are existing programs related to domestic violence support and sexual assault and intimate partner violence programs that are important to connect people. If we are able to have in place all of these current existing supports, but that they are integrated and offered as wraparound services, we will be able to decrease the incidence and prevalence and mortality due to HIV. As I mentioned, this is a huge team effort that has been essential and fundamental for us to be able to understand a bit better the epidemiology in Manitoba. I will stop my presentation here so Dr. MacKenzie can continue with the presentation.
Thanks so much, Zulma. So to continue on kind of the theme of what Zulma has been sharing so far, she highlighted that the populations that are disproportionately affected by HIV in Manitoba are women, specifically young women, as well as people who use substances. And so we're going to talk a little bit more about HIV pre-exposure prophylaxis specific to these populations. I have no conflicts of interest to declare. So what exactly is pre-exposure prophylaxis or PrEP? Well, PrEP is an evidence-based way to prevent individuals from acquiring HIV. So PrEP uses some of the same medications that are used to treat HIV, that is antiretroviral medications, but instead they're taken as prophylaxis by HIV negative people before possible exposures to HIV. Now, I also want to highlight that PrEP is one of multiple tools that clinicians have in their toolbox to help prevent HIV. So this is from our Manitoba HIV program, HIV prevention recommendations, highlighting that there are multiple ways to prevent HIV acquisition. And these include routine testing for HIV and other sexually transmitted and bloodborne infections, or STBBIs, condom use. Harm reduction for people who use injection drugs is critical. We have our pre-exposure prophylaxis there. Of course, there's post-exposure prophylaxis. So this is medication for people after they've had a higher risk exposure to HIV. And then we also, of course, have our antiretroviral therapy. Treatment is prevention for people who are living with HIV. We know that U equals U, undetectable equals untransmittable. And so having people living with HIV on treatment is also goes a long way towards HIV prevention at a community level. And then there's also prevention of vertical transmission, aiming to prevent transmission to infants and newborns. So we're going to focus on pre-exposure prophylaxis as a prevention tool. In Manitoba, pre-exposure prophylaxis, or PrEP, up until recently has referred generally to the combination of two different antiretroviral medications. That's tenofovir disoproxil fumarate, or TDF, and emtricitabine, or FTC. And together, these medications are in one tablet that in Manitoba is recommended to be taken as daily, once per day PrEP. You may also see it referred to by the brand name Truvada, although there are generics available. So this medication was first approved by the FDA for HIV PrEP in 2012. It was approved by Health Canada for HIV PrEP in 2016. The first generic form was available in 2017. And in Manitoba, we first had coverage under our provincial pharmacare program in 2021. And then, as Zulma mentioned, most recently, PrEP as well as antiretroviral therapy treatment became free to Manitobans just over a year ago in June 2024. Now we know that daily tenofovir or TDF-based PrEP is very effective but it's highly dependent on how often people are able to take it. And because we're asking people to take it every day, that's a really difficult ask, and people can miss doses here and there. What I'm showing you here is a figure that on the vertical axis shows the effectiveness of PrEP, and on the horizontal axis shows the percentage of participants in various trials that had detectable drug levels. So there's a variety of trials that have examined the effectiveness and efficacy of tenofovir-based PrEP. And you can see that there's a really strong linear relationship here. So the more adherent participants in these trials were able to be to the PrEP, the more effective it was at preventing HIV. And so we know that tenofovir-based PrEP is highly effective at reducing the risk of acquiring HIV, but it really depends on people being able to take it consistently every day, which is difficult to do. I also want to highlight that we do have a lot of data examining women who are at increased risk of acquiring HIV. Many of these trials examining TDF-based PrEP did look specifically at women. However, we have limited data, kind of less trial-based evidence looking at people who use injection drugs and substances. There is a study called the Bangkok tenofovir study, and that, rather than looking at the combination of tenofovir and emtricitabine, just looked at tenofovir, but did show for people who were able to be adherent to that medication, over 80% decreased risk of acquiring HIV. So we do have data, trial data specifically looking at people who use injection drugs. Now, in Manitoba, who is eligible for this new free tenofovir-based pre-exposure prophylaxis? Well, people have to have a Manitoba health number, which is a barrier for some people, and not have coverage for this medication through another federal or provincial program. They, of course, need to have an HIV negative test prior to starting pre-exposure prophylaxis. And in Manitoba right now, the province has outlined criteria that people need to meet for them to have coverage of this medication. So the three groups that are highlighted by our provincial criteria are MSM, men who have sex with men, transgender women and gender diverse people, people who use injection drugs, and then heterosexual people who may be at increased risk of acquiring HIV. Now, our province has a very detailed and somewhat confusing, I think, for clinicians, criteria for how they're recommending people be assessed for eligibility for pre-exposure prophylaxis. So they have criteria for MSM, transgender women and gender diverse people, outlining STIs previously, if they've used post-exposure prophylaxis before. They also mention a risk score that can be used called the HERE MSM risk score. For people who use injection drugs, they recommend an ARCH IDU risk index that can be used to help stratify whether someone may benefit from PrEP. And for heterosexual people, they specify that people should be having sexual exposures to other people who may be living with HIV or having a chance or who have a chance of having transmissible HIV. And I think from my perspective, these criteria can be overwhelming sometimes for clinicians maybe who are less familiar with HIV PrEP. And I did want to highlight that guidelines from other centers, so this is the recently released International Antiviral Society USA guidelines that were released earlier this year. They really kind of put aside all those criteria and recommend that PrEP should be discussed and offered to all sexually active persons, all persons requesting PrEP, and anyone who injects non-prescription drugs, uses substances, or who has a substance use disorder, without the need to limit access to specific criteria for sexual or drug use behavior or the required use of screening tools. And so my hope is, because I do feel like PrEP is very underprescribed in Manitoba, that we can move more towards this kind of thinking around PrEP rather than having people try to meet very specific criteria. We should be offering it to anyone who's sexually active or who's using substances, I think. Now, the approach to pre-exposure prophylaxis for TDF-based PrEP is fairly straightforward and follows algorithms that clinicians might use for treating things like high blood pressure or diabetes. So the first step in Manitoba is we need to confirm that someone is eligible for PrEP, although I think most people who are interested in PrEP would meet eligibility criteria. Then they need a baseline evaluation. So of course, that's going to involve baseline HIV testing, ideally with an antibody and antigen test as opposed to just a point of care test. Everyone should get hepatitis A, B, and C screening, as well as STI screening for syphilis, gonorrhea, chlamydia. And then down the road, if people are not immune to hepatitis A or B, they should be vaccinated or offered vaccinations if they're not immune. And then the rest of the baseline testing involves checking a creatinine for kidney function, urinalysis essentially for kidney function, a complete blood count, and then a pregnancy test if relevant. And then assuming that baseline evaluation doesn't have any contraindications for PrEP, then it's recommended that people start the tenofovir-based PrEP within 2 weeks of that evaluation, be followed up again in 1 month. And that's to check in with people, not only to repeat HIV testing and kidney function testing with creatinine, but also to check in and see how they're tolerating the PrEP, see if they have any questions, check in on how they're using it. And following that, people then go on to have follow-ups recommended every 3 months. And that's primarily for HIV testing, STI testing, checking a creatinine, ongoing pregnancy tests if relevant, and then hepatitis B and C can be screened if necessary annually is the recommendation. Now, it is important to emphasize the importance of follow-up HIV and STI screening for people on PrEP. And that's because we know that antiretroviral drug resistance, if somebody does acquire HIV, can develop if a person has been on PrEP when they're already living with HIV. We want to make sure that we diagnose people who may have acquired HIV so we can get them on treatment regimens rather than prophylaxis regimens. And we also know that STIs, active STIs that are untreated, can increase someone's risk of acquiring HIV, which is why it's so important for regular STI testing as well. Now, in Manitoba, the prescription of TDF-based PrEP is very straightforward. It's just writing it on a normal prescription pad, and then the prescriber needs to write meets EDS Part 2 for PrEP, and that will allow the pharmacy to get that medication covered under the new provincial coverage program. There's no other special forms that need to be filled out for coverage. That's it. Now, TDF-based PrEP has a long safety record. A few things that we watch out for side effects are renal function. So there's a small risk of nephrotoxicity from the tenofovir component of this pre-exposure prophylaxis regimen. And that can manifest as increases in serum creatinine, evidence of proteinuria, glycosuria, so glucose in the urine, hypophosphatemia or low phosphate in the blood, and acute tubular necrosis. And if people's renal function has a GFR below 60, then TDF-based PrEP is not a good option for them. There's also an association with decreased bone density because of the tenofovir. However, there's no additional recommendations for more intensive bone density screenings for people on tenofovir-based PrEP. The recommendation is to screen using the general osteoporosis guidelines. And then for hepatitis B, because the TDF-based PrEP regimen, those medications are also active against hepatitis B. If somebody is starting and stopping a TDF PrEP regimen, there's a risk that stopping that therapy could result in a flare of their hepatitis B. And so it's important for providers to know if somebody's living with hepatitis B so that they can watch for that. But otherwise, this is a very safe medication with a long track record of safety, and it's also safe for pregnant women as well. Now, this figure I wanted to show you to highlight some of the new PrEP options that are available for key populations. So here we have a list of key populations: MSM, transgender women, heterosexual men, transgender men, heterosexual women, and people who inject drugs. And for the purposes of this talk, I'm focusing on heterosexual women and people who inject drugs. The green means that there's a Health Canada approved indication for these medications. Red is off-label or potentially not recommended. And here we have our TDF PrEP that we've been talking about so far. So is approved by Health Canada for heterosexual women, not specifically approved for people who inject drugs, but is recommended in all guidelines for this population. For specifically MSM population, we have TDF PrEP on demand. Then there's a slightly different but similar medication that instead of TDF has tenofovir elafenamide or TAF in combination with emtricitabine. This is a one pill once a day regimen as well, also called Descovy. And up until recently was not indicated for heterosexual women or people who inject drugs. And more recently, you may have heard of a new injectable regimen. So instead of pills once a day, there's an injectable regimen called cabotegravir that is generally given every 2 months for HIV prevention. It is now approved by Health Canada for this indication. We don't yet have it in Manitoba, but we expect to have it by the end of this year. And while the Canadian pre-exposure prophylaxis guideline update has not yet been released, cabotegravir PrEP is recommended in guidelines from the World Health Organization, the WHO, as well as IAS USA guidelines. And so this regimen is one that I wanted to talk a little bit about next. So injected cabotegravir PrEP, or CAB long-acting, or LA, this is a long-acting integrase inhibitor medication that's given as an intramuscular injection. Of course, people need to first test HIV negative before receiving it, and then they can either move to direct to injection or an optional 4-week lead-in to make sure that they tolerate this medication. But typically, this schedule involves initially an injection at month 0 and 1, followed by every 2 months. And there is a 7-day window around the target date of injection to allow a little bit of wiggle room there. You may have heard of this by the brand name. It's called Apretude. Now, where did the data specifically for women come from for this study? Well, it came from a trial called HPTN 084, the LIFE study. And for this study, they looked at over 3,000 HIV-negative women who were sexually active, identified as cisgender in sub-Saharan Africa. And they randomized them to receive either this injectable cabotegravir regimen plus a placebo of tenofovir-based PrEP, or active tenofovir-based PrEP plus a cabotegravir placebo injection. And that's what this looked like. So group A here received the cabotegravir. They started with an oral lead-in of cabotegravir and a tenofovir placebo, then went on to receive their cabotegravir injections as well as tenofovir placebo. Whereas in the other group, they received placebo cabotegravir lead-in, active tenofovir PrEP, and then went on to receive placebo injections and an active tenofovir PrEP. This was followed by an open label arm of the trial that initially was planned just for tenofovir PrEP, but then cabotegravir did become approved through data similar to this. And so participants were allowed to choose injectable cabotegravir in the open label arm as well. So in this study, there were 40 HIV infections that were observed over almost 4,000 person years in the study. 4 of them were in the cabotegravir group and 36 were in the tenofovir group. And so in all, women in the cabotegravir group had almost a 90% lower risk of acquiring HIV compared to the tenofovir PrEP group. Now, it's important to know that of those 4 HIV acquisitions, there's important details around them. So one participant, their HIV was detected at week 33 in the trial, so after they received injection number 5. The study site found that that person had an HIV positive test using an antibody antigen test, but because this was a trial and they were collecting lab work throughout, they were able to go back and look at viral load testing for this participant. And they found that actually at study entry, this person was living with HIV with a positive HIV viral load, but the antibody test just hadn't gone positive. 2 other participants in the trial were randomized to receive the cabotegravir, but they didn't actually start receiving it prior to testing positive for HIV. And the 4th participant, their injections, which were meant to be every 2 months, weren't really happening according to that timeline. And there were 3 injections that occurred outside that recommended timeline, including the final injection visits, which were about 16 weeks apart instead of 8 weeks apart. And that participant also had really low blood levels of the cabotegravir medication. So no HIV acquisitions occurred among people who were receiving on-time injections for cabotegravir. They also looked at pregnancy outcomes and found that for people who developed a pregnancy during the trial, there were no significant differences between those people who were in the cabotegravir arm versus the tenofovir arm. And that led the IAS guidelines to say that the long-acting cabotegravir PrEP has a growing and robust safety profile in pregnancy and breastfeeding and can be used safely in these settings. Now, there are some side effects associated with cabotegravir, most commonly injection site reactions that typically decrease over time, as well as headache, fatigue, and nausea, which are also typically reported with tenofovir-based PrEP sometimes. There are also some medication interactions, so cabotegravir cannot be given at the same time as other medications that people might be on, so it's important to know what medications people are taking. In terms of testing and monitoring while people are on cabotegravir, we know that cabotegravir can delay the detection of early HIV acquisition just using standard antibody antigen tests. And so some programs are starting to recommend HIV RNA testing for people prior to starting cabotegravir if there's been a recent HIV exposure or HIV symptoms that might be present for seroconversion symptoms. We also know that cabotegravir drug levels decline slowly after injection and can stay present in the body for about 12 months. And so that means that if someone decides to stop cabotegravir, they could still have cabotegravir in their body for about a year, and means that they could acquire HIV with still some cabotegravir in their system, which could select for some resistance to integrase inhibitors. Now, we don't yet have access to the final PrEP regimen, and that is injectable lenacapavir. This is available in the United States as an injectable PrEP regimen every 6 months instead of every 2 months. And guidelines in WHO and the United States do recommend it as an option for both heterosexual women and people who inject drugs. You may know it by its trade name, Yeztugo. And this is an exciting medication because it's a brand new way of working against the HIV life cycle. So this medication is called a capsid inhibitor. And again, it's only given twice a year, which is really exciting as well. So was approved for HIV prevention in the United States earlier this summer. And the data specific to women comes from a New England Journal trial that was published last year. This trial looked at over 5,000 adolescent girls and women in South Africa and Uganda who were not already using pre-exposure prophylaxis and were sexually active with male partners. This trial was exciting because not only did it look at the lenacapavir injections, but it also looked at daily TAF-based pre-exposure prophylaxis, for which we don't really, up until this point, have good data exploring its use among women. And participants were randomized to receive either the lenacapavir injections with an oral placebo or the TAF-based PrEP with an injection placebo or the TDF-based PrEP with an injection placebo. And what they found at the end of the trial is that the group who received the lenacapavir injections, there were no HIV infections, and there was also a decreased risk of acquiring HIV among the participants who received the TAF-based HIV pre-exposure prophylaxis. This trial also looked at pregnancies and found no significant difference among pregnancy outcomes between the groups. And it led the IAS USA guidelines to recommend lenacapavir for prevention of HIV among pregnant people. The WHO also came out with similar recommendations, really saying that any of the available PrEP products could be considered in pregnancy and for breastfeeding for HIV-negative women. And we will soon have some information looking at people who inject drugs. So there's a study, the Purpose 4 study, which is currently enrolling, which will hopefully give us some data specific to people who use injection drugs, looking at the efficacy of lenacapavir injections. So to highlight, right now in Manitoba, our options for women and people who inject drugs are oral TDF PrEP. We will soon have options for injected cabotegravir. And I also wanted to highlight that the IAS guidelines, because of this trial I just told you about, did add daily TAF-based PrEP as an option that's recommended for women who cannot tolerate TDF-based PrEP. I also wanted to flag the Canadian guidelines, which were last updated in 2018, but we should see guidelines later this year. And then we have Manitoba-specific resources through the Manitoba HIV program for providers who are interested in prescribing PrEP as well. And that's it.